Yeah.
Very good. Is everyone hearing me okay? Is my volume good?
Oh, let me turn mine on.
Good evening. It is 5 o'clock on January 20th, and I will call this special meeting to order. We are meeting virtually tonight so we can work through some technology issues in our boardroom, and we hope to be back there for our next meeting. Do I have a motion to adopt tonight's agenda?
So moved.
Second.
Was that a motion for Ms. Smiley?
Yes, it was.
And a second for Ms. Stevens. Mr. Atherton?
Yes.
Ms. Doyle?
Yes.
Ms. Hauser?
Yes.
I vote yes. Ms. Moore?
Yes.
Ms. Smiley?
Yes.
Ms. Stevens?
Yes.
Okay, well, we have adopted our short agenda for tonight, and we will start with our CIP. I want to thank Ms. Jones and Dr. Dawson for recording our presentation this evening so that the board could review it before right now, and the public is able to view it if you click on the agenda and look at the video embedded in it. The full presentation is there, but I will pass to Ms. Jones if she has a few words for us before we start talking about it.
Thank you so much. I am pleased to do this, and I'm also pleased to not do the presentation a second time. We had a good time recording it yesterday, so I'm interested to know how that worked for you all at some point in the future. The only clarification I would like to make in addition to what I said in the presentation yesterday was I noted on the two studies that we talked about, the facility study and the plumbing study, that there was a possibility that we could move those up. I met yesterday with Ms. Rath, and we were able to identify some funding to where we can actually do that this year. We can make a recommendation to the superintendent to do so. If the rest of the board agrees, I know that you were interested in the budget committee meeting to see that happen. So I think we can make that happen if you all say, yes, make that happen.
Thank you so much, Mrs. Jones, and we will definitely make sure that we get some feedback after we see how this all plays out. We will be sure to follow up with you on that.
Thank you very much.
Of course. Do board members have any comments or questions about the CIP?
Well, one thing I do want to say is I like this format. I like allowing us to look at ahead of time. It saves time, and it also gives us an opportunity to formulate any questions or concerns that we might have. So thank you.
Thank you, Ms. Stevens. Ms. Smiley, did you raise your hand?
I agree with that. Yeah, there's always so much to talk about. And exciting news about the next facilities study in particular, and having time for that. I definitely think since the old one is 10 years old, getting another look at that is good. The only other question I had, there's some question about, do we spend the additional $850,000 on the improvements for mechanical and roofing for HES's Building 100, and sort of the previous facility studies recommendation and, some of the trade-offs there. I'm just curious, and I'm not sure who this is a question for, that understanding what our options there are feels important. And so I'm wondering on what kind of timing we might have more conversation about that.
So if I could say a couple words about that, the facility study that we did in 2013 really focused on the state of the buildings and didn't focus entirely on your expansion and capacity issues. I might suggest that when you look at the new facilities study, that you make that a component of the study, that they look at the schools for options for capacity, and that you flesh out a little bit more about what it means to take down a building and replace a building and that kind of thing. So that was a recommendation that came in 2013, that Building 100 be removed and replaced just simply because it was going to cost too much to do the maintenance there, and it really went past the value of the building. But I think digging a little bit deeper with a broader scope of work and another consultant in this next study might be in order. And I would also suggest whenever you move forward with the next study that the board have some discussion about what that scope would be. I know that you all have some interesting days ahead of you to talk about redistricting. I know that capacity and the SAT phone numbers might look different than they did, 3 or 4 years ago. And so you may be in a position where you're going to need to look at that elementary number 8 that has been on the books forever, but obviously not funded, and the SAT phone numbers didn't support it. But with the growth that you see in Methuen as well as what you see in Hillsborough, I encourage you to look very closely at that when the SAT phone numbers come forward, and that will kind of help you inform what your next step would be for schools, and then give a little bit more flesh to the facilities plan. Does that make sense, Ms. Miley?
It sure does. Thank you for that.
So I'm a little thrown on some of this, and I guess I don't exactly know where to start. I guess on I was hoping we just go more structured through the plan, because the plan calls for the replacement, the desperately needed, long overdue replacement of HVAC systems in our elementary schools. And that is, the bonds were issued in 2021. We have unreliable, I'm going to just use the word unreliable. I'm not going to recount how many failures we're having with the HVAC systems in these schools. So I guess my number was just starting with the basic plan that you've given us. What can we do? You want 2 to 3 years to get these systems in, and I'm curious what we can do to accelerate that timetable and minimize the disruption to our schools. So that's the first question, is how do we get this plan moving faster? The money's there. As I understand it, the money is there for us right now.
The money is there for you right now. It has not been. You're going to get the final cash from the bond in FY22. The bond started paying out in 2017, and because we didn't put on it until November of 16, so you started getting money in 17. Whenever the bonds passed, the schools both had to give a cash flow schedule. Am I feeding back to you guys?
If we just mute, we'll be good. Thank you.
Okay. Whenever they set up the bond distribution, they will not distribute the bonds all at one time because it has to fit within the debt capacity for the county as well. So we gave them a layout, if you will, a schedule, a timeline of the projects that we had programmed. And I think we were able to get $15 million and something over 3 bond sales, and we had to do that over 5 years. So the money didn't become available to us. Now, Chapel Hill had one project essentially that they ended up doing with their bond money because Chapel Hill High School went so far over. We are not in that boat because our projects are many, and we were able to, do what the county wanted us to as far as putting some timelines to them. As far as expediting the mechanical systems now, you do have Suit Associates, which is mechanical engineer, who's putting together the plan. Central is the one that will come out to bid probably in February. You'll look at those bids in March. And then thereafter, they kind of, the others are, I won't say less complicated, but I think the design process will go more quickly on those. And some of them will have some degree of disruption that might be less than the others. We will speak to Sued Associates about making sure those go forward as quickly as we can. There's a possibility we could do more than one school at one time. I say possibility only because I'm not sure that's possible. but I think that we may be able to move forward a little bit more quickly than what we've done. You know, obviously it won't take another 4 years to get the rest of them moving. But as far as the disruptions, the time takes what the time takes, because as long as you've got students in the building, we've tried to do a lot of work in buildings with students there and it's not been successful. Roofing work is an example of that. HVAC is an example. So some of them where we're only changing out equipment might be able to be done while the students are occupied or while it's occupied by students. But where you've got duct work and extensive work in the buildings, it's going to take the time it's going to take. So I think we've heard your concerns about moving forward as quickly as we can. And I think staff will honor that, and we'll certainly share that information with Suit Associates and ask them to give us an expedited timeline on it. I see you.
Sorry, can you just share who is Suit Associates and who are we bidding this out to?
Suit Associates is the mechanical engineer that's designing the 6 schools that I indicated in the presentation. And as far as who are we bidding it out to, you know, public bidding is you've got to put it out to anybody who wants to bid. We will usually the engineer will check the marketplace and go based on the size of the job. They will look at people who have bid public bids before or public jobs before. Not everybody wants to do a public job. So they will make sure that the people who are interested in doing public jobs are aware of the jobs. We, of course, post it on our website so anybody can see it. But as far as handpicking somebody and approaching them to bid, we can approach them to bid, but we cannot go any further than that.
So are we going to bid them all, or are we going to bid them one at a time?
We will bid, we're going to bid central in February. Those bids come in February. If we speak with Suit and they can expedite and put more, put more than one out to bid, I don't see that as being plausible, but we'll talk to them about that possibility. So my guess is they'll be bid one at a time, but they might be bid closer together than what we have done thus far.
Thank you.
There's some danger in putting a great lot of work on the street, because depending on the size of the job, if they price certain bids out of the market because they're not big enough to do it. And, you know, it's got its pros and its cons, but.
I'd be curious how, like, a district like Guilford or Wake or Charlotte that have so many schools, how are they doing it?
Well, first of all, they have got a staff of millions to take care of the projects. So they have them rolling all the time. And they put them out to bid the same way we do. I mean, public bids laws are public bid laws. They apply even to Wake and Mecklenburg. So they're having to do the same thing we are about designing it. They may design stuff in-house a little bit more on smaller jobs, but they're doing the same process that we're doing. And part of the issue is because they're doing it, you may remember when Wake did the $1 billion bond and flooded the market with projects, we literally could not get bidders over here because our jobs were of a size that it couldn't compete. So they're doing the same thing we're doing.
Well, that's why I wonder if we at least had the option of bidding them as a group of projects, that we might we attract some bigger companies that can scale, that can handle the scale. It's just a question.
Yeah, and the answer is, I don't know, because we've not done that, but I'm not sure it would be to our collective advantage to do that anyway. For this district and this size. There are a couple of places that we have talked about as staff that might look at a different application for like geothermal, and that's a place where not everybody can bid it and not everybody's interested in bidding it. So I don't want to limit our, what we could draw and what would be good for the school district by collapsing them all together.
Thank you, Ms. Jones. Ms. Doyle?
Thank you. Ms. Jones, I have a question just about time frame. What you and Ms. Smiley were discussing, there's the line in the document that was provided in Assembly that major capital expenditures at Hillsborough Elementary will be held in abeyance. And that was what you were talking about with Building 100 and seeing if we could have that evaluation in a new facility study. And I'm just wondering what that time frame looks like in terms of how urgent is the expenditures under consideration for Hillsborough Elementary, and what are you foreseeing as the timeline for that facility study?
Well, first of all, I think that there has been some equipment change out in Building 100 in the last year. So they're not in a position where anything is failing. And so I don't see any downside to that at all. And if it comes down to the conversation and we do have failed systems, it would be a conversation we would have to have about where we are in the conversation about the disposition of the campus and weigh that against whether or not we wanted to go forward with the money. The money is there if we want to spend it. It's not, there's no prohibition to spend it. We just need to do so deliberately, understanding what the options are and what the long-term outlook is.
Ms. Hauser?
In that context, here's what's a little confusing to me, because the Hillsborough Elementary conversation's been going on for years, not weeks or months. It's not a new conversation. And as far as I know, there is no plan to do anything from the building's perspective. And I don't believe we have any money either. So I guess, and we have a need that HVAC system is probably as bad as the others. So I'm just curious why Hillsborough Elementary is being singled out for questions when you could probably do that with every school. And again, no plan, no money,
So those are all valid points. And there was a discussion, it's been like maybe 2 years ago or 3 years ago, time gets away, when we were talking about redistricting, we were talking about the facilities and such, and there was a discussion at that time. Brenda, you may recall and be able to enhance my memory here, but it was really not something that we could come to agreement on, and so it just was tabled. Just because things get tabled doesn't mean the need goes away. And it may be such that you say, I want to keep that building. I, as a board, want to keep that building, and we just want to go ahead and keep putting the maintenance into it. And that's a decision that the board can make, and we would move ahead with whatever, just like, it was going to be there for 1,000 years, because it might be. So I don't know beyond that.
Yeah. Well, we just had a lot of historical perspective, and people in the community had things to say about it. We all know that. I'm not going to rehash all of that. But one thing that I did say at the time was that when the building that at 300 West Tryon Street was no longer useful for the all-white school, they didn't tear it down. It was repurposed. So in the Black community. So, that's what I was saying at the time. So that's because that's all that's left for us. Well, anyway, enough of that.
And I think those conversations were good ones at the time, and just to bring that to some kind of a decision would be what we needed to move forward or not move forward. And as far as the timing on it, Ms. Hauser, you mentioned a while ago, the county would normally have a bond issue every 5 to 7 years. I don't know, they have given us, as I pointed out in the presentation, they've given us quite an infusion of cash in big dollars over the past several years, and that's not typical of what they have done in the past. So I don't know whether that might be a plan to keep looking at that as an alternative to a bond issue or not. But usually, and not usually, always, new schools have to be supported by a bond issue. So if we are able to get the facilities plan updated and commensurate or coordinating with that, the board can make decisions about the redistricting, about their, when they see SAPFO capacity, when they look at what that says about needing new schools. Then you would formulate the bond package or a package of needs, if you will, that we would present to the county for financing. And if they chose to finance it, at one point they did some certificates of participation that really was the same amount as a bond. So they might go in a different direction than just a bond referendum, but we would need to have our needs firmly established and be ready to give them some dollars that we needed within the time frame. It's usually about a 2 to 3 year process with the planning process that we have to go through with the town of Hillsborough. The design process, we usually involve not a task force, but a design group to help design the schools like we did even with the addition at Cedar Ridge. So by the time you get that done, you're usually a year in planning, and then it'll take you a solid 2 years, probably 18 months to 2 years to build a school. So you can usually use as a benchmark for an elementary school a 3-year period from concept discussion to moving in and cutting the ribbon.
So, and prior to that, we have to do a plan, and we've got to look at what's happening with because our enrollment's flat pretty much. You know, there's COVID, which is affecting everything. So take your 3-year timetable, and then we're going to put a prelude on it. So it's probably more like a 4 to 5 year timetable before we could make we could have a new school. I mean, it's not something that's going to happen right away.
There's not.
Right. And that's all and again, I mean, I'm all for, we haven't gotten to the idea of the facilities and zoning studies, and I'm all for that, and definitely on a forward-looking view, but we have a need, right? We have the funding and the need for, but our elementary school, so far, we've only done Cameron Park, and people are waiting. You know, when I have grandparents tell me my kindergartners wearing coats in school, that's not okay with me. Or teachers or schools have to close, and they have had to, we've sent people home, because we don't have heat in the building. So that's just happened. We don't have to get into details, but these things are happening in our schools. So anyway, so I'm a little confused as to singling out HES for this, and I hope we're just for now, until we have another plan, I would hope that we would be moving full steam ahead with all our elementary schools to get those mechanicals fixed.
All the HVAC that's scheduled to be done, that will put you in a really good position across the district, with the exception of what we need to do at Hillsborough. So you will have good systems in every school at that point.
So then the natural question is, why not Hillsborough too?
And I think I just, I don't know how to say it again. It's if you want to say as a board, the building is going to be long-term, go ahead and do the repairs as necessary. That's okay for staff. I mean, that gives us direction. It's a matter of, I don't like to do work twice, and I certainly don't like to spend money twice. So being prudent and being privy to the conversations that happened in the past, just didn't want to jump ahead and spend money that then you turned around and said, oh, we're going to replace that building, or it really is a good idea to replace that building. And then we've spent $1 million that we could spend elsewhere. It's not a big obstacle for staff. We can do whatever it is. I'm just giving you caution that there might need to be some decisions made one way or the other on the building before you invest that almost $1 million.
Right, but just so I'm clear, to wrap this up, Hillary, we're saying it's really that if we were going to replace Hillsborough Elementary, it's a 3 to 5 year, that we're 3 to 5 years out to get that done too. If we had a decision to do that. Okay.
Yes, that's after the decision.
Mr. Atherton?
Thanks, Hillary. I wanted to comment too. I did like the format of us hearing the presentation, having some time to be able to review it. So, you know, like everybody said, I thought that was very effective for us to be able to see it. My comment is I want to make sure as we are doing these mechanicals, we are looking at giving teachers local control of the air. You know, as Bonnie and others have mentioned, you know, teachers, not only because the system isn't working, it is working and it's too hot or too cold. And, you know, we looked at that in the last one we replaced, and there are controls in each of the rooms, but I think that's a small thing that has great value, especially when you can't control this classroom's in the heat all day, or this one's shaded and, you know, you're getting overwhelmed with the volume of the blower. So I definitely want us to you know, consider that and make it a part of the plan, so teachers do have local control versus zoning just the whole wing, you know, if you will. I do have one other question, but I will save it as not important for approving the CIP, but it's more of a closed session question that I cannot ask right now. So I will save that till a closed session next week.
Very good. Do others have thoughts before we entertain motions? Do I have a motion to approve the CIP?
So moved.
Second.
I have a motion from Mr. Atherton and a second from Ms. Stevens. Ms. Doyle?
Yes.
Ms. Hauser?
Can I, just a question, how does the idea of accelerating it, the plan affect that? The CIP just says, here's the project we're going to do, but the acceleration doesn't have to be part of the motion, right? That's something, I just want to know how that factors into it.
No, you've given direction to staff and we will do that. It does not need to be a motion.
Yes, then I vote yes.
I vote yes. Ms. Moore?
Yes.
Yeah. Ms. Smiley?
Yes.
Ms. Stevens?
Yes.
Mr. Atherton?
Yes.
Thank you, board. We have approved our CIP, and thank you so much, Ms. Jones, for all of your work on this and your lovely presentation to us.
Thank
We
you.
appreciate that very much. I would like to give credit for the recording idea to Dr. Dawson. So thank you, Dr. Dawson, for thinking of that idea. Thank you all very much. I appreciate the work that I've been able to do with you all.
Have a great night. Thank you.
Thank you as well.
So the next item on our agenda tonight is antigen testing, and I believe we'll be hearing from Ms. Sharita. And I think Ms. Campbell from the Health Department is here, and also Dr. Hostler from Duke is here to help us talk through this item. Welcome, everyone.
Good evening, everyone. As soon as Amanda gets it pulled up, we can go ahead and get started. I thank everyone. We also have our two lead nurses, Penny Burton and Diane Rocker. They are both here with me, and they did assist a great deal in helping to pull this information together so that we could present this tonight to you all. And I think you all have had an opportunity to preview the slides. So we'll move quickly as we can through those and entertain questions as they come up. I guess I understand. Okay. All right. So next slide, please. And we do have Dr. Hostler and Margaret Campbell Margaret is from our Orange County Health Department, and Dr. Hostler is from Duke University School of Medicine. Next slide, please. So just to begin with, we wanted to kind of go over what the Binax Now COVID AG card type of antigen testing is. It's designed to detect proteins from the virus that causes COVID-19. It is intended for qualitative detection of the protein antigen from the SARS-CoV-2 through nasal swabs from individuals suspected of COVID-19 within the first 7 days of symptoms. The antigen is generally detectable in nasal swabs during the acute phase of infection. Next slide, please. So what does the North Carolina Department of Health and Human Services require to participate in this antigen program? The CLIA, which is a certificate of waiver for partnership, and this certificate we had in place. We did resubmit for a waiver because it did not cover the antigen test. So we had to have a clear waiver that specifically states which test we are talking about. So should the test change or anything like that, we would have to submit for a new one, as well as having to have other changes made to the waiver. We also must have a signed physician order, which would come through the health department for testing. And maintain an adequate supply of PPE. We would have to be able to properly handle and dispose of medical waste, have all staff complete the training modules, obtain parental and or guardian consent prior to testing, and then notification once a test has been performed, as well as the ability to complete the Department of Health and Human Services state reporting requirements, which we would work with our local health department to set up. Next slide, please. The pilot program actually began on December 14th. Districts signed up in partnership with their local health offices. Qualifying schools must have had people in-person classes, as well as have a parental permission plan, either a blanket and or individually as the incident occurred, to test. 3 million antigen tests will be available to school districts in North Carolina. The program will expand statewide in January, is what we've been told. We're not sure if that has happened yet. We have been asking questions, but we have not been able to find out. Right now, as far as we know, that program is closed. Non-medical personnel can be trained to administer this test, so it does not have to be a school nurse. Abbott Binax Now antigen testing is for students and staff members that develop or exhibit COVID-19 symptoms during the school day. I want to make sure that I say that part. So this is for people who, this particular program is for people who develop those symptoms during the school day. Testing is for students and staff in grades pre-K through 12. Next slide, please. So what does the what does the North Carolina Department of Health and Human Services antigen pilot program, what do we need, Orange County schools, to participate? I apologize. We need our parent permission forms, and depending on what the board decides, we will work with our Orange County Health Department to develop those forms and make sure that they meet the needs of both the health department as well as the school district. We would need documentation of training and implementation. So our nurses are able to use PowerSchool to perform the legal documentation on students, but nurses do not have a way to legally document on staff currently. And this would be something that we would have to take to our board attorney and work through with them. And if non-nurses perform the test, we need to figure out what those legal ramifications would be as well, because that would possibly be a HIPAA situation. The state reporting requirements, that entry can be done by a data entry or a data manager person. They would just need to be trained, because reporting this communicable disease is the law and it has to happen. So there are no wiggle room when it comes to reporting this back to the health department and the state. Supplies of PPE, hand hygiene materials, and other possible items must be an adequate supply and will need to meet the storage and handling of testing material requirements and any other CLIA laboratory requirements for the wave testing. Persons conducting the test must be trained and must follow wave testing requirements to ensure quality testing, and then additional nurses and or qualified staff to conduct the testing may be needed. Next slide, please. So there are some pros to the antigen testing performed at or near the point of care. Help public health officials identify and recommend isolation for people with active infections in order to minimize COVID-19 transmission. The test must be administered by trained staff associated with the CLIA certified laboratory that has the certificate of waiver. However, that person, again, does not have to be a medical professional. Some cons of the antigen testing: may be more likely to miss a current infection than the molecular test. That would be the RT-PCR reverse transcription polymerase chain reaction. I probably messed that last part up. But currently, there is not enough data to know if using the antigen test is effective for people with COVID-19 who do not have symptoms. Also, symptomatic persons must leave even if they test negative. So if I went down and tested for, because I had a headache or I popped a fever and my test came back negative, using our antigen test that we are talking about, I would still have to leave school. I would still have to either go get a PCR test, or I would have to, I would probably have to stay away from work for the 10 to 14 days. They will need the PCR test done in addition to the rapid antigen test before being allowed to return on campus. And so, due to the fact that the antigen test results may be false negative or false positive, the PCR test is the most reliable. This is a North Carolina Department of Health and Human Services exclusion requirement. So even if you tested negative, because of this, the fact that this test does have some issues with false negatives and false positives, the North Carolina Department of Health and Human Services is saying that you still must go PCR or be excluded from work and or school. Next slide, please. What are the challenges that we see? Not every school system, and we got these from the state and CDC, not every school system will have the resources and or training, including the CLIA certificate mentioned above, to conduct school-based antigen testing. We do have the CLIA in place, and we had it prior to this, so we were good in that aspect. The benefits of school-based testing need to be weighed against the cost and feasibility of such programs to both schools and families. Disposal of the resources for biohazard, time management for nurses, FERPA and HIPAA when we're talking about adults, and staff leave. What role will this play in staff leave if a person tests negative, but then we're saying they have to stay out of work or go get the PCR test? Antigen tests usually provide results diagnosing an active SARS-CoV-2 infection faster than a molecular test, but antigen tests have a higher chance of missing an active infection, even in symptomatic individuals, and confirmatory molecular testing will always be recommended for positive and negative test results. So whether you test positive and or negative under this pilot program, you will have to go and get that PCR testing to follow. Although antigen tests have not been authorized for use in asymptomatic individuals, the FDA and Centers for Medicare and Medicaid Services have allowed the use of these tests in situations where a rapid result is needed. Data entry to the state of test results would need to be submitted by Orange County Schools, requiring schools to learn the state system for submission. Next slide, please. What are other considerations and implications? A minimum of a month time to plan, prepare, and implement a school-based testing program like this. We would need that time, not just to get back our new CLIA, but in order to set up everything, get those parent permission forms together, make sure that we have adequate space, a dedicated infrastructure and resources to support the school-based testing. I said the CLIA waiver, mechanisms to report all testing results, both positive and negative, as required by the state and the local public health department, and plans for ensuring access to confirmatory molecular testing when needed, because sometimes antigen tests can give false positives. So we have to have a way for our staff and or students to be able to get that PCR. Ways to obtain parental consent for minor students and consent for students themselves, physical space to conduct testing safely and privately, and the ability to maintain confidentiality of results and protect privacy of all the individuals involved. So next slide, please. What is the district's recommendation? Well, it kind of is twofold. So one is no antigen testing in the district. Orange County has a functioning local health department, or refer staff and students to a contracted service, sort of like, for example, Star Med, which is a business or a testing site across the street from our local health department. Or if the board chooses to move forward, the following is recommended: both symptoms, free testing, random testing, voluntary testing with a blanket consent form, and funding for additional staff at a school or PPE supplies. So if the board says we want to move forward, we're saying we need to decide, or we need from the board a recommendation if we're going to do symptomatic people and random, or we're just going to do voluntary with a blanket consent. And then about funding if we need additional staff at each school to lift this, as well as PPE supplies, which may be needed throughout the remainder of the school year. Next slide, please. What does the board need to decide? Move forward or not with the antigen testing. If no, refer students and staff to a contracted services, and possibly suspend the district's North Carolina Department of Health and Human Services pilot testing application. If you decide to move forward, yes, symptom testing is free via North Carolina Department of Health and Human Services, or random testing. And even if we do the random testing outside of the pilot, I want to be clear about that, we will still need to work with our local health department to meet all of the legal requirements in order to do that testing. So we're not saying if any way that we go with this, we will have to work with our local health department to meet all the requirements that the state has put out there. We need to know whether it would be mandatory and or voluntary, and approve funding for additional staff to support possible testing, approve funding for additional necessary PPE, and then waive or suspend the contingency in order for K-1 to access in-person learning on January 25th. And I think that is the last slide. Are there any questions?
Thank you so much, Ms. Cobb, and thank you, staff, for putting all of this information together so quickly for us to review and discuss. Board members? Ms. Doyle?
Thank you, Ms. Cobb, and thank you to the staff who went to great lengths to do all this. I feel like I'd like to speak, since I was one of the proponents of investigating this program, and we've gotten a lot of information from local doctors, and I know we have people tonight as well. But as articles have been forwarded our way, I have to say I think this makes less sense than I originally thought when we requested to investigate it, because there is like a context to it, as you were mentioning, Ms. Cobb, that we have a well-functioning local health department. I wonder if this pilot program was intended for districts that don't have as readily tests available. There was a time when, tests were in short supply and they might take a week to get your results back, and that's just not the case. And I know in addition to the health department, we have several other testing sites in Hillsborough. So it's almost like creating an urgent care situation that has tremendous staff requirements and reporting requirements. And I just have a lot more reluctance about this program than I did originally, and I just wanted to share that. Thank you.
Thank you, Ms. Doyle. Oh, I'm sorry, Ms. Jubison. Yes, please go ahead.
I just wanted to make a quick comment because I know there's been some mention of HIPAA, and just wanted to note that as a public school system, Orange County Schools is not a HIPAA covered entity, even if you're performing this sort of medical testing. If you were to work with a contractor, they might be, certainly. But that doesn't mean that you don't have confidentiality requirements. Student medical information is confidential under FERPA. Employee medical information is confidential under the ABA. We would still have systems for keeping someone's test results confidential. But HIPAA is a law that applies to healthcare providers and insurers, and is not something that the school has to worry about. And I did want to ask just one clarifying question of Ms. Cobb. You mentioned that the DHHS pilot program, to our knowledge, is currently closed, that they have talked about expanding it past the 17, but there's not a date for that yet?
Correct. It is, as far as I know, it is closed. Margaret, Miss Campbell and I spoke today and checked on that. And as far as we know, at this point, it is still closed. They have not opened it up.
And our understanding of it is, at least as of now, if you wanted to use the antigen test, there is a way that you could basically request the antigen test through the state, through us, that would be separate from pilot program.
Thank you.
And Ms. Campbell, hi, this is Penny. So if we're able to access the test, then we would have to get protocols through our health department, correct?
Yes.
If that's going to be an independent type thing.
Yes.
Okay, thank you.
Well, it's Mackenzie. May I say something?
Oh, absolutely.
All right. Well, I just want to sort of like I'm joining Carrie on this side of the line is that I really, at this point, I'm not supporting the testing now that we have this additional information, and especially since it's, it's likely to miss a current infection. It's like, why put somebody through it if it might miss it? And we don't have enough data. That's what you told us in the cons, that there's not enough data to know if using antigen test is going to be effective for people with COVID. So, why? And it's a lot of expense and extra work. And it seems to me that the cons outweigh the pros, in my opinion. Thank you.
Thank you, Ms. Dr. Hassler, I just wanted to say that I really appreciate you being here and wondered if there was anything you would like to share with us before we continue our board discussion.
Yeah, sure. Thanks so much for having me. So I'm an infectious diseases physician at Duke. I'm primarily over at the VA. I'm the chief of our Office of Public Health and Epidemiology. I've been running our COVID response for the last, 14 years, it seems like. And then I co-own a company that gives infection prevention education and guidance to every major professional league in the country, athletic league, as well as some collegiate leagues. So we're the infectious disease folks for like the NFL, MLB, NHL. So all these folks that have tons of testing programs, which is why I bring this up. I totally agree with all the comments that have been made so far. I mean, in general, this is an okay test for symptomatic people. It's a terrible test for asymptomatic people. To the point where, it's, even though it's been lauded, there was a recent MMWR, that's CDC's publication that came out either yesterday or today, talking about the Binax now in asymptomatic populations. The bottom line is that the negative predictive value, so if you have a negative test, which is one of the reasons people were saying you could rule people out by saying, if you have a negative test, you don't have COVID. It's essentially about the same as asking someone, do you have COVID? And if they say no, that's about as good as the antigen test is. This was the same test that was used at the White House during the Rose Garden super spreader event when everyone was tested right before that, and obviously did not prevent any kind of infections. We don't use antigen tests in the hospital, in any of the hospital systems that I work in. And every major professional league that we've worked with has abandoned antigen testing due to the issues with the sensitivity, specificity of the test, and the fact that it just does not perform as well. And as was mentioned, it's a pretty heavy lift. I mean, it takes me 4 nurses working full days to test 120 veterans at the VA for COVID. It's a full-time job. I mean, every professional league that's doing large-scale testing has contracted with large companies to be able to carry this out. I think the bottom line is that testing is not prevention. So where we need to focus our efforts is on prevention, and that would be masking, hand hygiene, distancing. That's where you're going to have the biggest benefit. I certainly would not advocate for this in the asymptomatic population. If you're using it in the symptomatic population, there are still a lot of issues, as were mentioned, false positives and false negatives. And so you're still going to need a second test, which almost begs the question, if you're going to need a different test to begin with, why go down the path of even doing the first test?
Thank you so much, Dr. Hassler. That is very helpful information. Ms. Smiley?
I agree. And I have I was wondering, I think it would be helpful for us to separate also the sort of symptomatic testing of folks that it sounds like this North Carolina pilot is, and the screening in order to limit asymptomatic cases in the building. And there are, and many of these have just gotten started, but there are districts around the country right now that are doing screening testing, right? So New York City, state of Colorado, state of Utah, Maryland, Texas, Rhode Island, DC, the UK, Canada, like parts of Canada. There's a lot of school systems right now that are doing this screening testing. And I'm curious, Dr. Hassler, if you know much about whether they are using different, like, are there certain antigen tests where that makes more sense? Or if you have any context on any of those programs, because I mean, my interest is, you know, if 59% of cases are transmitted by people without symptoms, how do we get asymptomatic people identified early so that we're, especially with like a high level of community spread, we just have fewer COVID positive people in buildings. And so knowing that all those places are doing this, but what you're saying about, you know, if you know anything more about that and could speak to that, that would be helpful.
Yeah, the vast majority of places that are doing any type of screening are using PCR or a nucleic acid amplification test. So it doesn't necessarily have to be PCR, but some of the other ones like ID Now or LAMP assays, kind of getting in the weeds there. But the bottom line is most of them are using something where you're actually amplifying a sample as opposed to an antigen test, which is really just relying on having a high burden of virus present. And that's the big difference between antigen and PCR, is that with PCR, it takes a small amount of virus, is able to amplify it so that you can detect it. Antigen test, you have to have a large volume present already. Because the vast majority of infections are still spread by people who have symptoms, they may be spread during an asymptomatic phase. The focus for eliminating spread would really need to be on the kind of contact tracing and ensuring that you have appropriate risk mitigation strategies in place in order to prevent that kind of spread. I mean, you know, we did not have significant numbers of outbreaks within our health system outside of the context of people eating together in small workspaces until the last month or so. And even then, it was still people getting together, unmasking, and that's where you saw a lot of spread. You know, we have 4,000 employees that work in our hospital, and we've been doing, you know, we've been having people come in every day, and we have not had significant spread when we have universal masking in place. And obviously, it's a lot easier for us to try to enforce that in the healthcare system, but I think it can effectively be done in any type of setting. So I think that the bottom line is that if you were to do this as a screening modality, you'd need to be doing this multiple times a day to accommodate for the rate of false negativity, the false positivity, and the really poor sensitivity in asymptomatic spread or in asymptomatic patients. In that MMWR, they noted the Binax Now had a sensitivity of about 35%, which essentially means if you have COVID, it's going to pick up maybe 1 in 3 cases or so. So and that's, you know, that's not even mentioning the fact that then you need to go down the pathway of retesting them because of the false positive and false negative issues. So I think that it's a hugely labor intensive effort, and the juice is probably not worth the squeeze when you consider the fact that that's not going to prevent an outbreak. What's going to prevent an outbreak is all the other things we're talking about: masking, distancing, and adequate contact tracing.
And then can I ask a question about the symptomatic on the other side of, and not symptomatic, the sort of diagnostic. So I guess in this pilot, North Carolina pilot, that's symptomatic people. So I understand that right now the requirement would be, you know, even if you test negative on that, you still need to go get a PCR test. And I'm wondering if that has anything to do with the community prevalence in general, and if, you know, if there's any world where that might change, because the other, I mean, besides other than the, I think there are 2 problems in the short term, long term we're going to be dealing with. One is this idea of screening out people who are asymptomatic, and then the other is not unnecessarily quarantining people as well. Do you have any sense of whether in the future these antigen tests would have any value there, or are we still going to be relying on PCR tests?
Yeah, I think for symptomatic people, you're still going to need to have a PCR. There's just because of the inherent issues with what an antigen test is, where it is not an amplified sample. You're always going to need to have a PCR test in order to say, yes or no for disease for a symptomatic person. And that's really just, because, I actually think if you had a positive test in somebody who has symptoms, I would be fine saying you can stop there. The pilot program, it says they want to get a confirmatory PCR, but from an epidemiologic standpoint, I'd be fine saying if your pre-test probability, the likelihood that they have disease is already pretty high, and you get a positive antigen test, you could probably stop there from my standpoint. A negative test in somebody who has symptoms is not sufficient because the likelihood that they have disease, even if the prevalence goes way down, it's still going to be pretty darn high.
Yeah, and to tag on to that, from the guidance that the state has given us, if we're not part of the pilot program, if you got a positive test and you're symptomatic, we would consider that a positive and would treat it as such. I would say that, though I absolutely agree with everything that Dr. Hassler said about antigen testing, and that probably it is more work than we will get benefit from. Because of the sort of limited number of symptoms that the state has given us, that, okay, if students have, I think, these 4 or 5 symptoms, that is the grounds for exclusion. If you had testing for students that were symptomatic, but in other ways, that were not those 4 or 5 symptoms, then you could go ahead and test them. And if they tested positive, then, you've already identified that they have COVID, and, now they know they have to exclude. But I still don't think that small benefit is worth all of the work that it would be.
Thank you. Thank you so much. Board members, anyone else have discussion? Mr. Atherton, then Ms. Hauser?
Yeah, I'd just like to say that, I'm not supportive of this based on, what we're hearing right now. Fortunately, downloading some of the materials from the state, they have a nice flow chart. And as mentioned, asymptomatic literally says no symptoms, off-label use. And then it has this flow you have to go through. And then all cases of the antigen test points back to a PCR test results, which, now, as everybody mentioned, as soon as they test positive, now we have to start doing the trace analysis of that person and quarantining while we're waiting on the PCR or the results of that. Even in their own documents, they talk about negative results do not rule out SARS infection and should not be the sole basis for treatment. I worry about our nurses that would be, doing this test, even though if they had the symptoms, we would be sending them home anyway. The mental impact to our students, that would be, especially if it was surveillance or random testing, which I'm not comfortable with at all. But I just wanted to share, I don't think this is going to be a value based on what we know now. We didn't know this when we started, but now this does not seem a good use of our time and resources.
Thank you, Mr. Atherton. Ms. Hauser, was it you that I said was next?
Yeah, I just thought, I really appreciate. It's just a question for Ms. Campbell and Dr. Hassler. Is there a way for us to continue to monitor progression in this kind of testing? But I'd also just like to put a motion out there that we drop the antigen testing requirement from the reopening for KN1.
Second.
I have a motion from Ms. Hauser and a second from Ms. Stevens. Is there any discussion before I call the vote? Not seeing anyone, so yell out if I'm missing you. Okay, Mr. Atherton?
Yes.
Ms. Doyle?
Yes.
Ms. Hauser?
Yes.
I vote yes. Ms. Moore,
Yes.
Ms. Smiley,
Yes.
Ms. Stevens.
Yes.
Okay, so we have established that kindergarten and first grade can continue as scheduled since our air purifiers and lunch plans have been put together. I think that we need to also provide clarity about whether we want to suspend our bid to be in the pilot testing program at this time or refer anyone to other services, or was that, I just want to make sure we're all clear. Was that what we intended to say, that we don't want to pursue this?
Ms.
That everyone's under.
May I jump in?
Please.
I just want to, so that it's clear in the minutes as well, just make sure that we restate that the motion was essentially to revise the board's action at the January 11th meeting by removing the condition that there be a testing program in place before K1 can return. And the other conditions were a plan for meals eaten outside the classroom and the purchase of air purifiers for each classroom, and those other conditions have been met. Okay.
Correct. Is there any further discussion about these items? Dr. Felder, do you have anything else you want clarity on or questions for us?
Thank you so much, Chair McKenzie. The only other area that I'd like clarity on, I think you were heading in that direction, and that's around grades 2 to 12. So I just want to be clear about what the board's expectations are with regards to antigen, this antigen pilot program. Did the board want us to continue, or do we know that the contingency is removed for K and 1? Just want to be clarity regarding grades 2 to 12.
It's certainly my understanding that we're saying we're not interested in pursuing it at this time for any of our students and staff. Is everyone in agreement about that?
Agreed.
Yes, agreed.
Yes, we don't want to add more workload to our staff.
Agreed.
Yeah. Okay, well, Dr. Hostler, Ms. Campbell, thank you so much for being here tonight. Ms. Rosser, we appreciate all of your expertise in guiding us through these decisions. Yes, oh, Ms. Hauser.
Before you release our guests, and I don't know if you could just say that we can have this conversation. I understand Dr. Hostler is an expert in the vaccines that are coming out. And I was wondering if he can give us any guidance on availability. First of all, what is the J&J vaccine looking like? Because that's a single dose vaccine. And what might be the fastest way for us to create a program to get our teachers vaccinated?
Well, if you have any veterans, feel free to let me know. I'm happy to vaccinate them here at the VA. I think the bottom, yeah, yes, we are currently doing frontline essential workers, including people who work in schools. So any veteran, if you are enrolled in VA care, just dial the main number for the VA hospital, hit 0, and ask to be scheduled into clinic. The bottom line is that I don't have a good answer right now. There was a lot of hubbub from the federal Secretary of Health and Human Services about releasing the stockpile, and then which we were then gearing up to try to do a mass vaccination event and trying to get 20,000 veterans done in a weekend, only to find out that there actually did not exist a stockpile. And so I think as we're kind of processing this federal transition period, hopefully we'll get a little bit better of an idea of what actually exists and what our future allocations are looking like. I would say that the bottom line is I would encourage people to sign up for every avenue that they have available. So through the county, through any of the health systems where they receive care. And again, if there are, if they are veterans and eligible for VA care, through the VA as well. And then to get the vaccine wherever they can get it first. We were one of the sites for the Janssen trial. I'm one of the investigators on it. We don't actually have preliminary data, although it's or as an investigator, I don't have preliminary data, although it is being submitted to the FDA likely tomorrow. So I suspect that sometime in February, we'll probably have a decision from the FDA about the Janssen trial. AstraZeneca is a little bit delayed. That's approved in the UK, but that is unlikely to be submitted to the FDA here due to some trial irregularities until probably April. But I think the Janssen one I've been most excited about because it is a single dose. It's easy to store. It's easy to get out and vaccinate people with. I think the United States has purchased 100 million doses of Janssen. I don't know the timeline for delivery of that, but I anticipate if it becomes FDA approved sometime in the middle of February, we're probably looking at a small amount for February, March, and then a much larger amount starting in April or May.
Thank you so much.
Dr. Hostler, hi, this is Penny. When I was looking at the table for vaccine administration through North Carolina DHSS, it looks like most school personnel fall into 1B, and it's by age groups. It looks like, I think it's 50 and above, and then 24 to whatever, 49, something like that. Is that correct?
I think that's correct, although I'll be perfectly honest, because I work at a federal facility, we follow the federal guidelines, which are a little bit different from North Carolina, and so we're going directly by CDC. And so what we're doing is all frontline essential healthcare worker or frontline essential workers, including those who work in education, regardless of age. My wife is texting me that it looks like that's not the case anymore, and that it was simplified. So that may have changed within the last week from North Carolina's perspective as well.
So I will jump in for Orange County. So North Carolina last week changed their vaccine groups. They may change again. They will probably change again at some point because that is the nature of this pandemic. Right now, North Carolina is vaccinating, and Orange County specifically is vaccinating groups 1 and 2, which are healthcare workers and older adults. Those are like frontline healthcare workers, so patient-facing healthcare workers and older adults. Frontline essential workers are going to be group 3, so that's the next group that comes up, which is going to be our educators. And I will say that, yes, when it is your turn to try to get vaccinated where you can get right now in Orange County, our systems are so completely overwhelmed. So if it is not your turn, if we are not vaccinating your group, please, please, please do not try to register, because then we just have to remove you from the line, and it just takes extra time. And we are getting thousands and thousands of calls a day. So.
Ms. Campbell, if you don't mind, could you give us some idea? Do you have any idea? I know you don't have a crystal ball in front of you, but with regards to when teachers, educators will be able to access the vaccine, what is it looking like?
So we really don't have any sort of timeline at this point. Group 2, which is the older adults, people 65 and older, regardless of health conditions, is a very large group. So it is going to take some time. If we can get a third vaccine in the mix, and especially a third vaccine that only requires a single dose, that is going to speed us along very quickly. But yeah, it is going to take a while.
Mr. Atherton?
I had just a follow-on question to this, and Hillary, thank you for letting us have this outside the agenda discussion. So the question I had is, I've heard from the current vaccines, normally the day after, people tend to feel sick, right? They don't feel well. And I was curious of, one, how frequent is that? And the second question I had is on the single dose, is that also true as well? Because I think as a district, we need to figure out how we give teachers time available to take the vaccine, and second, have time to recover, right? Because if that's going to be true, I definitely want us to be forward thinking about that, but I just wanted to get your thoughts or comments around that.
Yeah, I'll start. I think that in general, it's people have an immune response that the median duration, so the average amount of time that it lasts is about a day or so. So for about a day after you receive the vaccine, tends to be a little bit more common in younger people, and tends to be a little bit more common after the second dose, because you've kind of primed the pump a little bit. But we're talking about relatively mild symptoms for the vast majority of people. In our health system, we've vaccinated over 3,200 employees at this point. I think we've had 3 people who have called out. We have encouraged them to get their vaccine the day before their day off. I'll tell you that, I'm 35, so in that relatively young cohort, and I had a sore arm after the first dose that lasted about 12 hours. And then I had a couple of muscle aches, so it felt like I had worked out hard the day before, which my wife will tell you I did not. And that was about it for about a day or so. We have had some people who have noticed some chills, say that it's a little bit of a rough night, after they get vaccine, but the vast majority of people, symptoms completely abate after about a day.
Okay, that's good to hear. And is that the same for the single dose?
Yeah, so within the trial that we've had, the vast majority of reactions are much less than you would get with the mRNA vaccines, so Pfizer or Moderna. And they're similar results, though, kind of flu-like symptoms for about a day at most, with a slightly lower percentage of people experiencing the symptoms.
All right, thank you so much.
Yep.
Okay, if there is, Ms. Hauser?
I wondered, I don't know if it's for Dr. Hostler or Ms. Campbell or the board, but I wonder if our board could petition, and that should it be the county, the state, the governor, to move our teachers, especially the teachers that are in school, on campus, up in the queue. And then secondly, could we be allowed to actually administer the vaccine on our campuses? So actually have doctors show up on our campus and vaccinate the teachers. That's it.
And so, sir, I'd like to just add one comment to that. Not only your teachers, but your other school staff that are working in the building right now.
Absolutely.
So I just want to jump in and say that I actually reached out to Senator Kouchie and Representative Meyer this morning, and I know you and I have spoken, Ms. Hauser, and they were supportive of us writing a letter about that, advocating for that. So any board member who is interested in working on that with us, you would be most welcome, but they are open to that. So we will write a letter on behalf of the board trying to advocate, and it couldn't hurt. I'll just say that. I don't know if it'll get us anything, but it couldn't hurt.
And I'll tell you, if we could get vaccine, I would be delighted to give it all day and all night.
And we thank you for that. So with that, I will take a motion to adjourn.
So moved.
A motion from Ms. Stevens. Is there a second?
Second.
I'm sorry, who was that? Ms. Moore? You?
Yes. Mm-hmm.
Okay, and I have a second from Ms. Moore. Mr. Atherton?
Yes.
Ms. Doyle?
Yes.
Ms. Hauser?
Yes.
I vote yes. Ms. Moore?
Yes.
Ms. Smiley?
Yes.
Ms. Stevens?
Yes.
Thank you so much, everyone. We're adjourned. Have a great night.